Hello and welcome to the FAQs. I'm Loren Clarke. In today's video, I'll address some frequently asked questions regarding the myPath melanoma test, starting with the very basics. What is its purpose and how does it work? myPath melanoma is an ancillary diagnostic test. It's designed to help us differentiate benign melanocytic nevi from malignant melanomas when we're unable to make that distinction confidently through clinical and histopathologic examination alone. Like other ancillary diagnostic methods such as FISH, CGH, and SNP array, the myPath test is typically used to guide the accurate interpretation of melanocytic neoplasms when the histopathologic features are ambiguous or conflicting. But where those methods detect abnormalities in DNA structure, the myPath test detects a specific pattern of gene expression that occurs in the vast majority of malignant melanomas, but in very few benign nevi. For context, all of the currently available ancillary diagnostic tools for melanoma can be grouped into one of three categories: DNA-based tests, RNA-based tests, and protein-based tests. Much of what we need to know about these tests requires little more than a basic understanding of simple cell biology, so bear with me for a 30-second review. Neoplasms, including benign nevi and malignant melanomas, are collections of individual cells, and each of those cells contains a nucleus that houses most of its DNA in the form of 23 pairs of chromosomes. And that DNA contains the genes that encode proteins. When a cell is prompted to produce a specific protein, the single-stranded template DNA encoding that protein is copied or transcribed into a messenger RNA molecule called an mRNA transcript. With the help of an organelle called a ribosome, that RNA transcript is translated into the polypeptides that are then assembled to form the final protein. Even when differentiating melanoma from nevus is uncertain at the clinical level, we can usually make the distinction at the histopathologic level. But when we can't, we can look for characteristic features of a lesion's DNA, RNA, or proteins. The laboratory technique will vary depending on which of these molecules we wish to examine. Immunohistochemistry and mass spectrometry analyze proteins. FISH, CGH, SNP array, and next-generation sequencing, or NGS, analyze DNA, and gene expression assays like the myPath test analyze RNA. Immunohistochemistry is well understood, and mass spectrometry is not yet in widespread clinical use, so for now I'll focus on comparing the DNA and RNA-based tests. FISH, ACGH, SNP array, and next-generation sequencing, or NGS, all target DNA. Their use in diagnosis is based on the premise that many melanomas have multiple structural abnormalities of their DNA, sometimes called mutations in this context. These methods primarily detect segments of DNA that are deleted, such as that highlighted here in blue, and/or segments that are duplicated or amplified, like that highlighted here in orange. Typically, these aberrations are detected through various means of comparing tumor DNA to normal or reference DNA. Most of these methods are best suited for detecting these relatively large aberrations, but NGS can allow detection of more subtle defects and may have a higher analytical sensitivity. To be clear, benign nevi contain structural alterations of their DNA as well, and many overlap with those found in melanomas. Therefore, successful use of DNA-based tests for distinguishing benign neoplasms from those that are malignant depends on knowing exactly which aberrations confer malignant potential and which do not. The myPath test does not detect abnormalities in DNA structure. Instead, it detects abnormalities in DNA function, particular genes that are activated and expressed when they should not be, or at much higher levels than they should be. The test does this by measuring the amount of RNA produced by a specific set of genes we call the melanoma signature genes. These signature genes are activated and transcribed into RNA at a very high rate in melanomas, and melanomas therefore contain many copies of their RNA transcripts. In contrast, they are transcribed at very low levels, or sometimes not at all, in benign nevi, and therefore nevi contain far fewer of their RNA transcripts. While these signature genes are highly expressed in melanomas, the genes themselves are not aberrant or mutated. The structure of their DNA is usually normal. Sometimes there's confusion about why the myPath test targets different genes than FISH, and this is the explanation. Both target genes involved in the pathogenesis of melanoma, but FISH detects genes that are structurally abnormal, while gene expression assays like myPath target genes that are functionally abnormal. The myPath test uses RT-qPCR, or reverse transcription quantitative polymerase chain reaction, to quantify the RNA produced by 14 different melanoma signature genes. Simultaneously, it also quantifies the RNA produced by a group of so-called reference genes, sometimes also called housekeeping genes, because the proteins they produce are basic elements of each and every cell. Unlike the signature genes, reference genes are expressed at essentially the same level in all cells, regardless of whether the cell comes from a benign nevus or malignant melanoma. Therefore, both melanomas and nevi will contain similar quantities of reference gene RNA, and this provides a built-in comparator. Melanomas contain far more signature gene RNA relative to the reference gene RNA. This controls for variables like RNA quality, quantity, and lesion size. For example, a small melanoma may contain less signature gene RNA than a larger one, but it will also contain less reference gene RNA, and so the ratio, and therefore the test result, is independent of the lesion size. The myPath test quantifies the RNA produced by 14 different melanoma signature genes. We selected these specific signature genes empirically by screening a large group of candidate genes in hundreds of melanomas and nevi of all types in order to identify those that are reliably overexpressed in virtually all forms of melanoma, but not in nevi. And our data showed that in most melanomas, regardless of size and subtypes, consistently overexpress a single gene known as PRAME, which stands for preferentially expressed antigen in melanoma, a set of 5 genes belonging to the S100A family, and a group of 8 genes involved in tumor immune response signaling. We call these 3 gene groups the signature subcomponents. The myPath test quantifies the RNA produced by each of the 14 signature genes and a set of 9 reference genes, and applies an algorithm that normalizes the signature to reference gene measurements and combines them into a single numerical score. So the output of the myPath test is a single number. And that number ranges from -16.7 to +11.1. That is the entire range of scores produced by over 1,000 melanocytic neoplasms analyzed in the myPath development and training cohorts, which included everything from barely perceptible junctional nevi to thick, ulcerated T4 melanomas. The lowest scoring nevus generated a score of -16.7, and the highest scoring melanoma produced a score of +11.1. The scale has 3 distinct zones defined by empirically derived threshold values. Scores of -16.7 through -2.1 are classified as benign. Scores of 0.0 through +11.1 are classified as malignant, and scores of -2.0 to -0.1 are classified as indeterminate. The myPath report simply shows the numerical score and its corresponding diagnostic classification as benign, malignant, or indeterminate. There is no interpretation within the context of histopathologic findings or any other subjective analysis involved. The myPath test was designed to maximize objectivity and reproducibility as well as accuracy, and our clinical validation studies in patients with documented outcomes have shown that it accurately differentiates benign from malignant in the vast majority of melanocytic neoplasms, including those that generate diagnostic uncertainty, even for experienced dermatopathologists. I'll share a few examples from one of our recent studies. This lesion from the right shoulder of a 60-year-old male was examined by 7 experienced dermatopathologists and favored to be a recurrent nevus by 2, a recurrent or sclerosing melanoma by 1, and was classified as indeterminate by the remaining 4. The myPath score was malignant, a score of +1.5. 4 months after this biopsy, the patient developed melanoma within multiple axillary lymph nodes. Disseminated melanoma involving the small bowel and colon arose shortly thereafter, and the patient succumbed to disease within 2 years. Given the age of this patient, I suspect very few dermatopathologists would simply dismiss this lesion as benign, but it generated some controversy among 7 expert dermatopathologists, 3 of whom went no further than designating it a meltump. The myPath result was definitively malignant, however, at +6.1. 10 months after this biopsy, metastatic melanoma was detected within the patient's lungs, and 3 years after that, within the small bowel. And for this lesion from the abdomen of a 34-year-old male, favored diagnoses ranged from traumatized nevus with reactive atypia to nevoid melanoma. The myPath score was squarely within the malignant range at +6.7. A sentinel lymph node biopsy was performed and was negative, but 3 years later, metastatic melanoma was detected within multiple right axillary lymph nodes. When a melanocytic neoplasm is ambiguous, clinical outcomes offer the only objective evidence of what is genuine melanoma and what is not. And our data have shown that the myPath result and the patient outcome align in the vast majority of cases. No diagnostic method is 100% accurate, however, and it's important to consider the results of any ancillary test within the context of all other relevant clinical and histopathologic information. An ancillary test result is often a critical component of the workup, but it should never override a preponderance of contradictory data. And all methods have specific limitations, including the myPath test. One limitation is that we developed and validated the test using primary cutaneous melanocytic neoplasms only. The test is therefore only valid for primary melanocytic lesions of the skin. We have not characterized its performance in non-melanocytic lesions, metastatic melanomas, lesions from sites other than skin, such as lymph nodes or mucosa, and it is not reliable in specimens that lack a representative portion of the lesion in question, such as re-excisions in which the bulk of the neoplasm has been eradicated by a prior biopsy. And the limit of detection is about 10%, meaning that reliable results require at least one focus in which roughly 10% of the cells are those suspicious for melanoma. The second limitation is that roughly 5% of all lesions submitted for testing cannot be analyzed due to insufficient RNA quantity or quality. A panel of quality control analytics are performed in every case, and specimens that fail to meet quality standards are canceled automatically. RNA quality, not quantity, is almost always the culprit, and it's often the result of excessive RNA cross-linking that occurs despite adequate tissue fixation. This can be frustrating, but we prefer to issue no result rather than a result that's potentially compromised by specimen integrity. In summary, the myPath melanoma assay is an ancillary diagnostic test for use as an adjunct to clinical and histopathologic examination. It can produce false positive and false negative results, just like every other diagnostic method for melanocytic neoplasms, including histopathology. Like any medical test, its results must be interpreted within the context of all other relevant information. It's not a replacement for histopathologic interpretation, nor is it a substitute for judgment. In other words, it's a tool, not a crutch. But our data show that it accurately classifies the vast majority of cases and provides a much-needed measure of objectivity in the otherwise very subjective process of interpreting diagnostically uncertain melanocytic neoplasms. Thanks for watching. I always enjoy a thoughtful discussion about this or anything else related to the diagnosis of melanocytic neoplasms, so get in touch with comments or questions at lclarke@myriad.com.